So we're going to move on to the second speaker in this session. It's my pleasure to welcome Dr. Chris Wadsworth to the stage, who is a consultant gastroenterologist at Imperial College. And he's going to revisit this question that is, as we've heard, key for patients, and that's stenting.
Thank you very much indeed, and thank you for asking me to speak. And I don't have any disclosures. So we've already heard today some discussion around the indication for pre-surgical drainage, but my talk today is a bit more general about the techniques that we can use for placing stents into patients with cholangiocarcinoma and areas of potential inequality within the UK system. It's focused, and what we're trying to do to improve those towards the end of my talk. So I know you've seen lots of pictures like this over the last 24 hours, but just to recap, the liver drains bile down the main bile at the common hepatic duct, past the gallbladder, and into the common bile duct, and then into the duodenum. And this is obviously the route of excretion of bile and associated substances into the gut. The purpose of stenting in cholangiocarcinoma varies from patient to patient. So sometimes we undertake an ERCP to aid diagnosis, and that's the primary reason for doing it. An indeterminate stricture where we're not sure if it's a benign stricture or malignant, and we need to know for sure before we can make a definitive management plan in the MDT. We will undertake ERCP for that specific purpose and then place a stent as a secondary target, but that's relatively rare. Most patients with cholangiocarcinoma at the hilum or in the distal bile duct will have jaundice, and most of them will not be going direct to surgery or to surgery ever, unfortunately. And that's the bulk of the cases where stent placement either with ERCP or PTC is undertaken. As we've already heard today, biliary drainage is not a prerequisite for surgery, but in a jaundice patient it frequently is required. And certainly in chemotherapy, if the patient has significant jaundice, biliary decompression is required before chemotherapy can commence. An important reason for decompressing an obstructive biliary tree is to improve the patient's symptoms. Itch, fatigue, poor appetite can be very, very debilitating, and it's important to improve that biliary drainage to relieve those symptoms. In some patients, if that's all the treatment they're able to have or want to have, it will prolong their life. If someone has a bilirubin of 500 and they remain unstented, they will not survive more than a month. And we will prolong their life expectancy by a short period of time by providing them with good biliary drainage. And the final indication I've put up here is we frequently undertake ERCP to unblock blocked stents. So this is, I guess because of the more effective drugs that are now available for advanced inoperable disease, it's more and more common that people are coming back at the year mark with blocked stents, and they require clearance of those, sometimes restenting, sometimes RFA ablation within the stent to unblock them. And I think in some ways that's a positive in that people are living longer now with some of the new treatments and are requiring stent revision more frequently. I'm going to talk about two modalities today: percutaneous transhepatic cholangiographic approach to biliary stenting, and also ERCP. But I'm a gastroenterologist and I do ERCP, so that's the major part of my talk. But as you've already heard today, both of these techniques have a role. You've probably heard already talk about this. There are some parts of the world, there are some regions of the country here, and there are some hospitals or regional centres within those regions that have somewhat different practices, and that a lot of that is dictated by local expertise. And it's far better to have a very, very good PTC than a poor ERCP, and vice versa. So local expertise is important, and also the technology that's available. There are some parts of the world where the metal stents that we rely on in the UK are not economically feasible in their healthcare systems, and in some of those environments, PTCs and long-term PTDs are actually more appropriate. So it's what stents are available, it's expertise, and what the resources are available in that healthcare system. Success rates are pretty comparable, and the risks profile is different. You can get pancreatitis with a PTC, but it's much less frequent. Pancreatitis is the commonest complication of ERCP and affects about 8% of people having an ERCP. But you'd struggle to give someone a pneumothorax with an ERCP, but that is a recognised complication of PTC, for instance. PTCs are undertaken by radiologists in the fluoroscopy room. It's all done through the skin, local anaesthetic, often sedation, with the patient lying typically on their back. And the biliary tree is punctured through the skin and through the liver, and a wire is passed down through the bile duct, through the stricture and into the duodenum, and then if appropriate, a stent can be placed over that. The other factors that we consider when we're determining whether patients have a PTC or an ERCP, and we'll talk about ERCP in a little bit more detail in a moment, patient factors and disease factors. So the location of the stricture. Strictures that are at the hilum and infiltrating above the hilum typically will proceed to PTC in the first instance. Patients who've got a stricture that's subhilar, so below the hilum, and the left and right liver is in continuity, will typically, or strictures below that in the common bile duct or ampulla, will typically go to ERCP. But there is variation between centres, and particularly with hilar cases where the level of the stricture can be somewhat debatable and the right approach is debatable, it is effectively mandatory in the UK that that case is discussed as a tertiary HPB MDT, and a formal MDT plan is made about the correct next step. And patients with hilar strictures should not be going to ERCP without MDT consensus. There are some patients who've got post-surgical anatomy, for instance, after a gastric bypass. Bariatric surgery is diminishing now because of the new drugs that are available, but there was a significant increase in patients undergoing bariatric surgery with gastric bypass. And although you can undertake ERCP, it's a massively more involved and risky process, and those patients typically would be diverted to PTC if ERCP would typically be the preferred initial approach. And comorbidity. Some patients who are very, very sick with other health issues may not be fit for either procedure, but PTC with the patient lying on their back, not having to go on their front like they do for ERCP, and being able to have perhaps lighter sedation, sometimes offers a lighter touch option for a patient who's very, very frail and not fit for an ERCP under general anaesthesia. So these are some pictures from a PTC just to illustrate the point. The white is the contrast that's been injected into the bile ducts by the radiologist through the skin, and they've threaded this catheter down into the duodenum, and this is the stricture here where the white disappears, and these are the swollen white blood bile ducts above, and that's just at a higher magnification. They've then punctured the right-hand side of the liver as well after stenting the left. They've punctured both. They've stented the left and then they've stented the right. So this patient has ended up with bilateral palliative bare metal stents to the left and right liver as a definitive drainage procedure for a hilar cholangiocarcinoma. In ERCP, we've got at least one extra screen. So again, it's undertaken with fluoroscopic control, but you can see here we've got an X-ray picture, but also an endoscopic picture in the duodenum. And this operator has introduced a wire through the ampulla, which is here. They've done a cut, which is this sort of slightly charred area here to open things up. They've passed a wire up into the bile duct, and a stent's been deployed in that picture into a distal stricture. PTC does now offer the option of biopsy. There are devices on the market you can biopsy over a wire, but there are more options available in ERCP for achieving histological diagnosis. So this is a tight stricture at the hilum here, and this is the ERCP. Brushes can be threaded up over the wire to brush off samples for cytology, and biopsy forceps can be passed all the way up and actually take chunkier biopsies. And if you take 4 biopsies from an intrabiliary stricture, you can achieve diagnostic histology in over 75% of patients with cholangiocarcinoma. The other option we have at ERCP, and to a lesser extent via PTC, is a single operator cholangioscopy. So through the standard ERCP scope, we can introduce a second scope, like a baby scope, which has a sort of replicates, but at a much smaller scale, the ability to biopsy, see, provide light, irrigation, and suction. And this is the inside of a normal, smooth-looking bile duct. This is an abnormal bile duct with cholangiocarcinoma. You can see neovascularization, there's stenosis of the lumen, there's spontaneous bleeding and ulceration. And these are those tiny biopsy forceps being used to take little spy bite biopsies. Once we've done any biopsying that we need to do, the plan would then be stenting, and very analogous to the target of that palliative PTC stenting. Our approach would normally be to selectively cannulate the right and left liver and put bare metal stents into both sides of the liver to maximise drainage. And our aim is to normally extend those down into the duodenum, because as I've already said, some patients do develop blocked stents, and if the lower margin of those stents is visible to you in the duodenum, cannulating them at a repeat procedure, getting up into the liver using RFA, using dilatation, using other techniques to clear the stents out, is much, much easier than if the bottom of the stent lies somewhere up here, because threading a wire almost blind up the bile duct, lower bile duct, cannulating those stents selectively becomes almost impossible. So these are things that being thoughtful at the index first procedure can be really helpful down the line if problems occur. So in terms of types of biliary stent, I've put some examples across the top. So plastic biliary stents are the cheapest option. They're completely removable. We would typically use them in cholangiocarcinoma or suspected cholangiocarcinoma where histology wasn't clear. We were still thinking there might be a benign process going on. If we'd been asked to do an ERCP in a patient who was going for surgery to selectively drain one half of the liver, you might choose to use a straight plastic stent because it's removable, it's easily removable. Some surgeons, or many surgeons, would prefer not to have a bare metal stent within the half of the liver that they're trying to retain. In patients where we have histological confirmation or there's an MDT decision that the patient has a confirmed cholangiocarcinoma and we're doing a palliative procedure, we would tend to use a bare metal stent. These are more expensive, but their patency is much longer than a plastic stent. And of course, that's very important. And the cost saving, which would be several hundreds of pounds between a bare metal stent and a plastic stent, is completely and utterly abrogated by the cost of repeat procedures or admissions with blocked stents and sepsis. So from a cost-benefit analysis, it's a no-brainer, even though the cost of the stents is significantly higher. These are here just for completeness. People do ask about them sometimes in meetings. These are new dissolvable stents, but they only really have an application in benign disease, and even that's debatable. And they actually have, you can get them off the shelf and they allegedly fall out after 12, I think that's supposed to say 20 and 90 days, because they dissolve at different rates, or components dissolve at different rates and they drop out. We use some fully covered stents and we use partially covered stents occasionally. These are used where, in distal strictures particularly, where we're not crossing the hilum, so we can safely place a covered stent. It appears to reduce tumour ingrowth, and it's removable, so it's an option in patients where the diagnosis is still uncertain, but even more expensive. Early complications of biliary stenting, and effectively these apply to PTC and ERCP, but into different levels. Infection after procedure is more common after PTC slightly than ERCP, normally with fevers and abdominal pains within 48 hours of the procedure, and is generally very responsive to antibiotics. Sometimes it might suggest that the bile duct's not draining properly and further interventions required, but if the index procedure has gone as planned, that's unlikely. Pain after procedure, that's something we're not very good at warning patients about. If you put a metal stent, either percutaneously or ERCP, into a tight malignant stricture, it hurts as the stent expands. And we should be warning people about that before their procedure, because it can be quite frightening afterwards. You think something's gone wrong. Actually, it hasn't. The other thing is we need to be responsive and prepared for the patient to have plenty of analgesia while that stent's opening up. Bleeding, significant bleeding occurs in about 1% of ERCPs. It's thought to be slightly more common in PTC. This can require blood transfusion. Very, very rarely it might require angiography, and very, very rarely surgery to correct. Stent migration with modern techniques, modern stents, is very, very rare, certainly in this time frame, and would generally indicate that the procedure's not quite gone as planned and a stent hasn't gone quite where it was meant to go, rather than it being a true primary stent migration. And finally, occasionally in PTC, but much more commonly in ERCP, pancreatitis. The pancreas sits right next to the bottom of the bile duct, and when we're fiddling around at the bottom of the bile duct, in about 8% of patients we will cause a demonstrable pancreatitis. Fortunately, it's normally mild, although it doesn't feel mild to the patient because it's very painful, but after 3 or 4 days the pain settles down. But in a small minority that can be life-threatening, and the overall mortality from these sorts of procedures is around 1 in 1,000. Late complications of biliary stenting, I wanted to talk about because it's a common question we get from patients, and something that's not done very well in the UK health system and elsewhere, is people's stents go in, they recover over 24 hours, they go home, and 3 months later, 4 months later, and it always happens at 1 o'clock on a Saturday morning or when someone's overseas, suddenly they're in trouble. They start noticing their urine's going dark, fevers, jaundice. So the commonest cause of this is cholangitis, so an infection in the bile duct, and that's usually because the drainage is not optimal anymore, and there is either debris in the duct or there's tumour ingrowth at the top of the stent or within the stent. In terms of assessing the patient, it's important that we know about any evidence of jaundice, dark urine, pale stool, and fever is really important. And we really encourage our patients who've got stents to have a thermometer at home, because if you're feeling feverish, measuring your temperature, knowing what your temperature is really informative if you're ringing 111 or you're going to speak to the GP or you're seeking advice from your hospital team. In terms of management, in cholangiocarcinoma, it's attendance at hospital. It's starting antibiotics, as soon as possible if there's evidence of infection. It's attendance at hospital for re-imaging, because we would never go in and start trying to revise stents, unblock stents, put more stents in without having a new, fresh roadmap. So an up-to-date CT scan of the liver, what's draining, what's not draining, is crucial, along with the blood tests. So starting antibiotics, re-imaging, blood tests, and then typically an ERCP or sometimes PTC to drain any obstructed sectors. Delayed bleeding is really uncommon and normally relates to a stent eroding into a big vascular structure. I'm not going to talk about it in detail today because it's very, very rare, but patients should be aware that if they develop copious black diarrhea or vomiting of blood, they should seek urgent emergency medical attention. So in terms of, I've covered most of this, but when patients are discharged after having a stent placed, there should be some form of action plan in place so they know what to do, what action to take if they develop any issues with their stent. They should have a thermometer available. If travelling to remote areas, they should be given backup antibiotics. There are a lot of people, particularly if they've got a late stage of disease, they want to travel to visit relatives, they want to do the trip that they've been planning for their lives, so they go and do that, and if they get septic in the middle of nowhere, it's a disaster. They have to cancel the holiday, they end up in a hospital in the middle of nowhere. So providing them with antibiotics to facilitate that, to keep them as safe as possible while they go on their travels, is very important. We have to be particularly vigilant during chemotherapy. If people are neutropenic, they're much more susceptible to biliary sepsis, and it can be catastrophic. So it can be, very, very rapidly life-threatening, and there should be no delay to treatment. And patients should be encouraged and facilitated to seek advice from 111, their GP, their CNS, their hospital team, an urgent care centre, or in the worst-case scenario, the emergency department. Very briefly, I'll just talk about some innovations in stenting in cholangiocarcinoma. I've talked about these at previous meetings, and there's been very little progress in novel materials or drug elution of chemotherapy agents in biliary stents. The EUS-guided drainage for failed ERCP or PTC and distal bile duct strictures, so distal cholangiocarcinomas, is reaching prime time, and it's now in the BSG guidance that for distal biliary strictures where ERCP fails, proceeding to ERCP-guided biliary drainage is an appropriate next step. And in many tertiary centres now, that's becoming established practice in favour of, in place of PTC, which was the previous salvage technique after failed ERCP for distal strictures. So in terms of some challenges in stenting in cholangiocarcinoma and inequalities, I think there's still, and we talk about this every year, but speed of access to the full range of the best treatments is still very limited. It's very geographically variable within the UK and certainly around the world. MDT-led treatment plans, there are very clear protocols for distal strictures, and often distal strictures can be stented with ERCP pending MDT discussion. Hilar strictures should not be stented before MDT discussion. Genuine informed consent is difficult in the UK, the way the UK system works. Often patients arrive in an endoscopy suite, either in the big hospital they're in or in a different hospital across town or across the region, 20 minutes before they undergo the procedure, and the formal consent process starts then. And that's something that can and should be improved with trying to share information about the procedure with patients before the day of their procedure where that's possible. Clearly in emergencies it's not, but in the 90% of patients where it isn't an emergency, we should be doing this very, very well, not as a sort of a second thought, as a sort of an afterthought. Comfort during the procedure is a challenge. In many parts of the world, ERCP is not undertaken with sedation. It's undertaken with general anaesthesia or very deep sedation with an anaesthetist. But still, 80 to 90% of the ERCP in the UK is undertaken without an anaesthetist, just with sedation. And that adversely affects success rates of the procedure and patient experience. And there is some evidence of PTSD in some patients who've undergone very traumatic ERCPs. And that's not acceptable, but still seems to be practice in very many centres. Our aim should be for patients to have a successful procedure and the fewest possible interventions, and there is still wide variation between centres in that regard. We should be minimising complications, and when they happen, because they will, and complications do happen, we should be very, very good at managing them as well as possible. We should be trying to integrate our local hospital and regional units well so that patients don't fall between the gaps on discharge or in the follow-up of any issues with their stent. And having access via either a CNS or a dedicated post-procedure helpline can be very, very helpful. I won't go into this in any detail. There's been over 20 years now of attempts to improve quality at a national level in the UK in ERCP, and that work's ongoing. There has been some progress in the last couple of years, but it's still work in progress. I'm very pleased to say that last year's version of the updated BSG guidelines on cholangiocarcinoma really carefully considers biliary drainage indications, appropriate techniques, and is a very, very useful resource in regard to the drainage element of patient management. One of the little things that we're hoping to work on, we are going to work on this year in a project, we've got a fellow who's agreed to take it on, and we're going to try and involve patients via AMMF, is trying to develop some resources for AMMF's website and some of the a leaflet to add to their current leaflets around ERCP and PTC, and I'm sure that some of the patients will be asked to contribute to that process, and that will be made available obviously nationwide. So thank you for your attention, and I think we're doing questions later, so I'll go and sit down. Thank you.